You today to James Locke, MD, PhD, who is the Eric Rothenberg Professor of Psychiatry and Pediatrics at Stanford University School of Medicine and the Senior Associate Chair in the Department of Psychiatry and Behavioral Sciences. He also directs the clinical program for eating disorders at Stanford Children's Hospital. Dr. Locke has been treating children and adolescents with eating disorders since 1987. He has been active in research, examining treatments for eating disorders in youth, as well as cognitive and neurocognitive processes associated with these disorders. Dr. Locke has been recognized for his accomplishments by the Academy of Eating Disorders, the Academy of Child and Adolescent Psychiatry, and the American Psychiatric Association. He has published over 200 peer-reviewed articles and books on eating disorders in youth. Big welcome to Dr. Locke. And just a quick reminder for housekeeping, if everyone could please mute themselves. Thank you.
Thank you very much for that kind introduction. So I want to show these two slides. And this is an outline of what I'll be talking about today, just very briefly reviewing the eating disorders, and then something about the role of hospitalization, family-based treatment, the model that is the predominant transdiagnostic treatment for eating disorders in youth, an overview of the data about this for AN and BN and for ARFID, and some time for questions and discussion. Just getting started, anorexia nervosa, just to remind you, is the core feature are a refusal to maintain a body weight that is appropriate for height, nutritional health, growth, or fertility. There used to be a specific cut point for that, but 85% or less. But now we've redone that so that it's not a specific cut point, it's a clinically meaningful weight loss. It's associated with severe dieting, extreme exercise, sometimes binge eating and purging, but in that context of low weight. And there is a distortion of perception of appearance, weight and shape. And for bulimia nervosa, there's an overvaluation of weight and shape as a source of self-worth and self-esteem. Weight is in the normal range, and the worries are accompanied by binge eating and compensatory purging, either vomiting, laxatives, other kinds of purgatives, or exercise. ARFID, the newest of the most common of the eating disorders in youth, avoidant restrictive food intake disorder. This is a feeding disturbance associated with a lack of interest in food, avoidance based on sensory characteristics, concern about some bad effect from eating, like vomiting or severe nausea or allergic reaction, all these leading to a persistent failure to meet appropriate nutritional and/or energy needs. So usually these kinds of disorders are associated with significant weight loss or to achieve expected weight gain, nutritional deficiency, dependence on enteral feeding or oral supplements, and there needs to be some functional impairment as a result. About 1 in 100 of adolescents develop anorexia, 4 in 100 bulimia, 4 in 100 binge eating disorder, and 2 in 100 avoidant restrictive food intake disorder, and then 4 in 100 with subthreshold eating disorders. You kind of add those up, those numbers add up to a significant percentage of youth that have eating disorders or eating disturbances. Eating disorders are serious, can lead to medical problems, low heart rate, low body temperature, problems with blood pressure, hair loss, growth problems, bone loss, death, about 1% a year of increased mortality risk for each year one has anorexia nervosa. overall mortality rates for anorexia are amongst the highest of any psychiatric disorder. Psychologically, these disorders are associated with depression, anxiety, obsessive compulsive disorder, and high suicide rates. Socially, missed school, poor social development, achievement degradation, decreased marital rates, and decreased fertility. So the first of the eating disorders that was described was anorexia nervosa. In the medical literature, there were some clinical descriptions in the 1600s by John Morton, but formally designated anorexia nervosa by Sir William Gull, who's Queen Victoria's physician. This is the fellow on the left looking, I don't know, pretty grim. And he wrote, the patient should be fed at regular intervals and surrounded by persons who would have moral control over them. Relatives and friends being generally the worst attendants. Any relatives or friends out there have children? Pretty harsh view. Jean-Martin Charcot, the French neurologist, sometime pal of Freud, as the French sometimes are, even more directly, wrote, it is necessary to separate both children and adults from their father and mother, whose influence, as experience teaches, is particularly pernicious. Speaking about anorexia nervosa here. And so these two fellows who were on the vanguard of the phenomenological descriptions of anorexia nervosa had a pretty dim view of families and parents. And that view cast a long shadow on how clinicians viewed anorexia nervosa and its treatment and the involvement of families for a very long time. And so what this view meant was that children with anorexia nervosa, 12 to 13 or 14-year-olds, were institutionalized for years at a time away from their families. Now, if that worked to cure anorexia nervosa, given all the things that we know about how bad the outcomes can be, it might be worth it. So we want to know whether it works or is helpful. So there's not a lot out there, but there are two studies, both done in the UK. One was published in 1991 by Arthur Crisp, who was a child psychiatrist at St. George's Hospital in London. The average age of these young people with anorexia nervosa, these were all young women, was 19. And what Arthur Crisp did was he randomized patients, these young patients, to receive either assessment only, that's that red line, inpatient treatment, which was a very focused and relatively long-term, about 4 to 6 months inpatient treatment, or outpatient treatments, these two non-specific outpatient family and individual care or just an outpatient group therapy. And this is percent of expected body weight, and this is time. And I guess one good piece of news, if you can think of it as good news, is that no treatment, assessment only, led to no change. So treatment helps. That was good news. But these three lines actually are statistically identical. They may look different on the graph, but in fact, there were no differences. So this inpatient treatment arm, the patients in it didn't actually do any differently than the ones that were outpatient. Oops, sorry. This happens when I'm on Zoom. Simon Gowers, who also worked at St. George's Hospital, but then moved up to the middle of the UK into the Birmingham area, did a study. He was also a child psychiatrist and did a study published in 2007, where he randomized, in this case, adolescents. The mean age was 15 in this study. And here we have BMI on the vertical axis and time on the horizontal axis. And he had specialized care, which in this case was CBT, general CAMS Care, which is their child mental health service. So they got whatever they got, and an inpatient program, which was directed very specifically, about 3 to 3.5 months long, for eating disorders, very specific. And we can see in these lines, there's no difference in the lines. Now, I want to make sure that we have a clear understanding about what the implication of these studies is. Well, one, I don't want the conclusion to be that inpatient treatment is never helpful or won't be helpful. That's not what they say. They say that on average, it doesn't lead to better outcomes, on average. But that's important too, because that means on average, if you're expecting inpatient care to make a big difference in outcome, these studies don't support that. What it does suggest is that for adolescents, at least with anorexia nervosa, outpatient treatment is viable, so that separating children from their families, is not necessary, as Charcot would have suggested. So hospitalization is not a cure. Now, those of us who've worked with anorexia nervosa for a long time know this, but these two studies actually fly in the face of a lot of behavior, which is we hospitalize kids with anorexia nervosa or take them away from their families because we think that will help them, despite all the evidence to the contrary. So for years, when I came to Stanford after I finished my training, I ran an inpatient medical psychiatry service at Packard Children's Hospital, which I still do today. We, at that time, hospitalized kids medically and then kept them psychiatrically. And their average length of stay at that time was about 4 to 6 months. So the first part of it was medical and the second part was psychiatric. Couldn't keep doing that for a bundle of reasons. But in any event, what I felt as a clinician, that these patients weren't getting the best care. These patients were, we would get their weight up and then they would be discharged, and they would get whatever they got when they left, and we would be seeing many of them again soon. As soon as 2 to 3 months passed, they would have lost the weight that we had really carefully helped them achieve, and then they would go home. And then and we would always say, oh, well, those outpatient people and those parents don't know what they're doing. And we were had the grand idea that we were doing the great work, that we were doing good things, but we weren't really curing anything. And so I began to be frustrated by that after a few years, and found a model of care that had the only treatment that had any evidence that would be effective. And it was a study published in 1987, and by now it was 10 years past that. And it was something called the Mosley approach. And it had been written about in a descriptive way in a chapter, and an article had been published showing that for adolescents with short duration of AN, they would do better with this approach. Now, the study was very small. The whole study had 80 people in it. 20 of them had bulimia, and 20 of them, additional 20 were adults with AN, and another 20 were adolescents that had been ill for over 3 years. Only those who had been the 20, that means in 2 groups, 10 in each group, of that was a signal that they had done better using family approaches over individual approaches. We'll talk more about that in a minute, but there wasn't much. But it was something. And I was interested in trying to study that treatment further to see if I could help the kids that we were trying to treat. And that started a long journey, which I will take you through today, about developing an evidence base for interventions for anorexia nervosa, bulimia nervosa, and ARFID in youth. I went to London and met with the originators of this approach. This was Christopher Dare, a child psychiatrist, and Yvonne Eisler, who is a child psychologist, and Gerald Russell, who was a professor of psychiatry at the Mosley in their eating disorder program. And in talking with them over Chinese food in the middle of London, I described to them my wish to study the treatment further, and that to do so, I needed to write a manual to do that, because I knew I needed to have a replicable treatment. And Chris Dare agreed to help me with that. That manual became something. It's very funny because to me, at least, they thought, oh, manual. So they said, I think Gerald Russell said, oh, such an American thing to do. And at the time, I took that hit, but when I actually wrote the manual with Daniel LaGrange, who had studied at the Mosley and was a colleague at that time at Stony Brook, had been at Stanford previously, but I hadn't known him. When we wrote the book, and being the American that I am, I asked Gerald Russell to write the foreword, and he agreed, because once he saw it, he said, "Oh yeah, this is kind of useful." And part of understanding FBT is to understand its origins in family therapy. And I don't expect any of you to have like a huge depth understanding of family therapy. Some of you probably do, but from Salvador Minuchin's work, there's structural elements. There's attention paid to the way the family is reorganized when trying to deal with an illness. From Salvini Palazzoli, the systemic family work, there's the approach, the general stance of the therapist, which is consultative and not directive. From Jay Haley, the American family therapist, kind of the bad boy of the family therapy school. There are strategic elements where there are paradoxical interventions, including the way that we build a relationship with the family initially by sending both care and warmth, but really rather terrifying message about the harms that could come to their child. And then from Michael White, the Australian family therapist, then from the narrative school, we take externalization or separation of the illness to try and pivot the family away from blaming or seeing the child as the problem and rather seeing the illness as such. None of these particular ingredients is paramount in how you do the work. You're going to be using each of those as you go through the process of doing family work. So it wouldn't be right to characterize FBT as a structural family therapy or a systemic family therapy or a strategic family therapy or a narrative family therapy. It truly is an integrated therapy. FBT was designed as an outpatient treatment for kids who are out of hospital, medically stable. It's an outpatient treatment. It's very specifically designed to restore weight, something that might have been done in an inpatient refeeding program in the past, and aimed specifically at restarting adolescent processes which have been interfered with the development of anorexia nervosa. It depends on having a therapist, pediatric support, and a psychiatrist, if indeed there are medications needed. It's expected, depending on when you identify the problem, that medical stability will sometimes require brief hospitalizations at the beginning. In addition to those 4 schools of thought that inform FBT, there are these 5 assumptions, I call them fundamental assumptions, that really inform all of the therapist's behavior and interventions. One is an agnostic view as to the cause of the illness. Neither parents nor the adolescent are seen as having caused the problem or the root of the problem. This is really important because it frees the family to look at other issues, like the actual problem in front of them, rather than trying to look for cause. Now, families want to know the cause sometimes and are preoccupied with that initially, often. And so it's important that the therapist identify early on that we are not trying to get at the root cause in anorexia nervosa treatment using FBT. As I mentioned, the systemic therapy approach is a consultative one. The therapist does not direct the family. Here's what you should do. Here's how you set things up. No, that's not the strategy. The strategy instead is to help the family learn and change their behaviors by empowering them to use information that you provide them to process and decide how they're going to manage in their family the challenging behaviors that anorexia presents. And that's empowerment. It's one of the great pleasures of FBT, from my perspective, is the stance. You, as a therapist, you are able to join the family in the dilemma, but you are not seen or should not be perceived as being the cause of any change. That's the family. You are helping them think through the changes they will make. Often families come in feeling guilty for having caused the eating disorder, for feeling that the child herself is a problem. She's rebellious, she needs attention, or so on. FBT is very clear about anorexia is an illness. And just a pause here, if you look at psychiatric illnesses over time and cross-culturally, you'll see a fair amount of variation in how depression is expressed, how psychotic features and schizophrenia are expressed symptomatically cross-culturally. And you will see the same with anxiety disorders. Anorexia doesn't vary. It is the same in China as it is in Norway, as it is in Canada, as it is in Singapore. And I know this because I've seen it everywhere, and because the description that I mentioned, John Morton describing in 1600s, you would recognize anorexia nervosa as being the same disorder then as now. Very compelling psychiatric syndrome, in other words. For all of the worry and concern that body image pictures and so forth, media and so forth, those things have not changed the fundamentals of anorexia nervosa over time. The other thing this treatment is, which it's very practical. We are really, really trying to disrupt excessive dieting, over-exercise, food weighing, mirror checking, all the behaviors that reinforce anorexic thinking and behavior. So it's very directed at those symptoms. There are 3 phases to FBT. The first phase, and this is the kind of ultimate phase that people mostly think about when they think about FBT, and that's the parents are put in charge of weight restoration in their child. And this obviously runs diametrically opposed to what the traditional view, that is from Gull and from Charcot, that the families are bad influences, pernicious influences, poor caretakers. The opposite is the view here. And parents are put in charge of helping their child to gain the weight, block the maintaining behaviors at home, in their homes and in the schools in which they are living. In the second phase of treatment, parents guide their child to take up again normative refeeding and eating and exercise processes. So they hand over the reins, but they hand them over carefully and as the child demonstrates capacity to manage them. Only after the child has been able to gain enough weight and to demonstrate management of eating and weight, do you turn to adolescence and how it's been affected? And very briefly, one spends some time thinking about, in the phase 3, how anorexia has affected adolescent development, not the other way around. So, as I mentioned, when I started to do this work, there was one small study published in 1987. That's that one. There were 40 adolescents in that study. As I said, 20 were over 3 years in duration and 20 were under. And so that's where we started, 1987, which for a disorder, which I showed you, was described in the 1870s for the first time. Over 100 years went by before there was even a randomized clinical study of adolescent anorexia nervosa. It's kind of shocking given everything that I've told you. And then we have the studies that followed, and I'm having trouble with my cursor here. And you'll see here, these are all the studies that I'm aware of, and I follow the literature pretty carefully. These are all the studies that have been published for adolescent eating disorders with an intervention for using family-based treatment. And what I want to point out here is, to the point I made about that little visit to London and that manual, which was such an American thing to do. The manual was published 2001. After that, I want you to look at the ends. What happens? What happens is, except for pilot studies, the ends are large enough now to actually be able to justify a conclusion about efficacy and effectiveness. At this point, it's still not, I don't want to be tooting any major horns here, but there have been about 1,100 kids studied with AN and BN kids in randomized studies, 929 of them with AN and about 300 with BN. There are 12 studies, 10 for AN, 3 for BN, 12 different sites in 4 countries, 9 single sites, 4 multi-sites, 4 follow-up studies, and 1 meta-analysis focused on FBT. That was published a while ago and probably needs to be done again, but in any event, these are the, this is the database, the overall database. One of the studies I want to look more carefully at is one that we did comparing FBT to an individual therapy that was quite focused on the adolescent's development. And I have here 3 pictures of some of the, I think, sentient people who inform this particular kind of individual approach. The first is Hilda Bruch there, the Freudian analyst who wrote The Golden Cage, a very famous book about anorexia nervosa. And she wrote, excessive concern with the body and its size and the rigid control over eating are late symptoms in the development of youngsters who have been engaged in a desperate fight against feeling enslaved and exploited, not competent to lead a life of their own. So what she's saying here is the problem is feeling enslaved, exploited, and not competent. And these are symptoms, late symptoms, of this fundamental problem of incompetence, exploitation, inefficacy, that kind of thing. So treatment should focus on these, and if that's the case, these other things will dissipate. This is Arthur Crisp. I mentioned him earlier, from St. George's Hospital. He wrote, and I apologize for this sentence, the British are usually such excellent writers. I struggle with this sentence, but it's got so much importance in it. The avoidant position in anorexia nervosa is therefore a profoundly psychosomatic one, rooted in the seemingly miraculous and certainly unique capacity to reverse pubertal process and hence all of its social and psychological impacts. So what Arthur Crisp is saying is anorexia leads to avoidance, and needs to focus on therapy needs to focus on getting adolescents started again. Anne Moy is a clinical psychologist from Wayne State University. She's in private practice nowadays. She worked on the first American study, which was published in 1999 by Arthur Robin, that compared family therapy similar to FBT to individual therapy. That therapy was called ego-oriented individual therapy at that time, really a mouthful, right? But it was a small study with 36 kids in it, but it seemed to indicate that FBT, or family therapy in this instance, was not yet FBT, was superior at helping children gain weight, but was similar to adolescent-focused therapy, which we ultimately named ego-oriented individual therapy, in changing psychological state around eating in children and adolescents in the study. So she wrote this: the sense of ineffectiveness, interpersonal distrust, and poor identity formation makes the pursuit of illness appealing and an alternative to individuation. That's fundamentally what she's saying in this quote. And what her therapy, which was studied, did was focus on those elements of the psychological development, sort of integrating some of the points that Hilda Brooke made and some that Arthur Chris made. So as I said, this study that was published out of Wayne State had 36 kids in it, not large enough to make conclusions. So Daniel Grange and I studied this treatment in a larger study of 121 kids. And we randomized them to either receive adolescent-focused therapy, which was the individual therapy that I was just describing, or family-based treatment, which I've described already. So what I want you to, this is an outcome slide, and one of the first things that kind of came up in my work was we didn't really know what we should be aiming for in terms of treatment. And this actually turns out to be a big issue, because if you aim low, then you leave children with significant symptoms for which it's harder for them to overcome. So in this study, we aimed high. We wanted to promote recovery. And by recovery, we defined that as normal weight, 95% expected, percentile BMI for age, height, and gender, and a normal eating disorder examination score within one standard deviation of the norms for your age. And that basically means these children, if you saw them, weighed them, and talked to them about eating, they wouldn't look different from their peers. That's recovery. We had intermediate outcomes, which is, in this case, was weight over 85% or normative weight, or no response, or normal EDE, but that wasn't very common, or no response. And what we have here in this chart are full recovery are the dark aspects of the bars. Intermediate outcome are the grays, and the white is no really significant change on weight or thinking. What basically you can see here is adolescent-focused therapy. If you look across time, end of treatment, 6 and 12-month follow-up, FBT, end of treatment, 6-month follow-up, and 12-month follow-up. Basically, the rates of recovery are 20% versus 40%. And that's pretty stable over time. That makes sense. So it's about twice as much. Intermediate outcomes, that is this gray area, didn't differ too much, and non-response rates didn't differ too much. So FBT was helpful, about twice as helpful on average, at leading to full recovery than individual therapy. Just a few things about this. These were kids who presented with the full range of comorbidities. There was no special, they did need to be below 85%. They were underweight, in other words. These were kids that presented clinically routinely. There was nothing special, no major exclusions at all. Dropout was really low in both treatments, about 15%, and that's really low for a randomized clinical trial. and there were no differences between the two groups. So both AFT and FBT were acceptable to families, and people did their treatments. Interestingly, by 3 months, about 40% of the FBT patients had gained weight to 95% expected percentile BMI, and only 20% or half of the AFT had. Further, hospitalization was, again, much greater in AFT, which was about 37% were hospitalized versus 15% during the treatment course. So that those, not only were the outcomes different, the process was different. Children in FBT gained weight quicker and required less medical care than those in AFT. When we designed this study, we were really interested in hoping that there would be a specific group of patients that would benefit from AFT. And we thought maybe older adolescents might do better because it's a therapy that's aimed at talking about problems, and that might be easier for a 17 or 18-year-old compared to a 12 or 13-year-old. We thought comorbidities might make a difference, that kids with more comorbidities might do better in AFT than FBT, because families might have more trouble with some of those difficulties. But we didn't find any of those. So there were no moderators, so-called, that those are baseline variables that interact with treatment so that it's affected. What we did do when we looked at moderators, we looked at this. It looks complicated, but it's really not so complicated as it looks, this particular slide. What we did here was we identified 3 variables that were really important in terms of looking at outcomes. One was the Yale-Brown-Cornell obsessive compulsive features, that's the YBC, around eating. It's not OCD, it's around eating. And if you had a high score, which is bad, versus a low score, and this is on a median split, and you got FBT, you did much better than you did in AFT. If you had a low score, there wasn't much difference. The EDE, which is the cognitive component of eating disorders, if you had a high score, which is bad, you did much better. This is recovery rates. You did much better in FBT than you did in AFT. If it was a low score, you didn't have much difference. If you were a purging type, which is about 30% of our population, you did better in FBT than AFT, and not so much difference if you did not. Oops, sorry. So what does that mean? I thought about this. I went, oh, this is really interesting. And basically, it kind of went counter to all my intuitions initially, because these are markers clinically of difficulty and severity. You know, the sickest kids did better when their parents helped them. Now, my bias was, well, the sickest kids are going to need the specially highly trained therapists doing AFT work. You know, they're going to be the ones that can do that. But in fact, when I continued to think about it, how I think about it now is the kids who are really, really high-end severe cannot work in the model of AFT. They need the external support of their parents to make progress. Without that, they don't have the bandwidth to use the therapy. Now, those of us who had worked with individual approaches, which I certainly had done and had found them useful at times, kind of wondered about why some people got better and some didn't. This sheds a light on that. These kids would have looked clinically very similar. Weight-wise, they would have had very similar presentations. But when you get into the details of obsessive-compulsive features around eating, the specific higher scores on the EDE, and the presence of purging, that's where you get a real differential response. So sicker kids did better when their parents helped them. So we looked at, so that sort of said, okay, well, on the whole, FBT is pretty good compared to individual work of this type. We looked then at other family therapies. Again, family therapy had been used for years, but understudied, not studied systematically. So we did a study, 7 sites, one in Canada. 164 kids were randomized. Again, very few exclusions. You needed to be medically safe for outpatient treatment, and basically you needed not to be psychotic, and you could be in the study. And we didn't find major differences in clinical outcome between the approaches, meaning that recovery rates were similar between the two groups, and weight change and EDE changes were similar between the two groups, which again flew in the face of the view that Gull and Charcot and others had for many years said that families can't be helpful. Indeed, families using either of these two family approaches were useful. However, there were differences in the rates of recovery, weight restoration. Again, as in with AFT, was really much faster in FBT. And what this led to was a decreased utilization of high-cost hospitalization. And you can look here that the costs were over twice as high for SFT than they were for AFT. I mean, for systemic family therapy. Interestingly, to me, was that for the small group of patients where they had high SIBOC scores, and that's now not around eating and weight related, this is general obsessive compulsive features, systemic family work was more helpful. This was an exploratory finding needed to be confirmed. I just want to show you the graph that illustrates what happens in treatment, just to make it a little clearer. This is the number of hospital days used by the cohorts, and the red line is FBT, and the orange line is systemic family work, and this is time. And what happens in the first 8 weeks, they look pretty similar in terms of hospital day use, right? But then after that, more or less, FBT flattens, but SFT continues to need hospitalization. Why would that be? Well, as I said, FBT leads to greater weight restoration quicker. And it's about at 8 or 9 weeks that you expect, as we pointed out, for FBT to be made significant inroads. So these kids are less medically vulnerable and they don't get hospitalized. I probably should have said this earlier. There was a requirement for hospitalization if kids became medically unstable according to the same criteria across all the sites. So you can see here, that's the output of that. So then another question about hospitalization and about treatment was, well, should we keep, when we gets hospitalized, how long should they stay? And what should we be aiming for? And this was a study done at Westmead Children's Hospital. And this study was, which is in Australia, outside Sydney. And Westmead randomized 82 kids to either short stay, which is just medical stability, or to weight restoration, was to 95% of expected percent mean BMI. Afterward, everybody got FBT. So the question was, did kids who you fully weight restored in hospital do better than kids who did not have that one just medically stable? And you can see the number of days here on this chart that were used by the two groups. 15 on average for the medical stability group, and 37, over twice as many, in the group that were weight restored before starting FBT. What happened? Well, it's not on here, sorry. What happened was no differences. There were no differences in outcomes for relapse, so no difference in hospitalization use post, no difference in recovery rates, no difference in any parameter related to outcome at 6 or 12 months after hospitalization. What this study shows you, and the outcome shows you, is that you don't need to keep kids in hospital to full weight restoration in order to get good outcomes. In fact, there's no reason to, because if they get FBT, that's really important. it's not like, oh, any old treatment afterwards. It's FBT that they got afterwards. Everyone got it. So, and that FBT systematically applied across the cohorts basically didn't matter whether you kept them for longer. So this would mean, on the whole, that you don't need hospital to keep kids in hospital for so long, saving huge amounts of money and a huge amount of duress of families and children in their system. There was one other interesting finding, which was that obsessive compulsive features, again on the SciBox, actually was a problem for inpatient use. So kids who stayed longer in hospital with high SciBox scores did worse than those that were in short hospitalization. Why? Maybe those of you who worked on such units know that they are quite programmatic, almost obsessional in their strategies, so that it reinforced a lot of the same anxieties and worries. That was the theory behind it. So it made it harder for them to change when they left, if they stayed longer. One of the most interesting things about FBT that we learned is that you can see early response that's highly predictive of longer-term outcome. So if you get a weight gain of about four pounds or so by week 4, this predicts recovery in about 80% of the kids. Unfortunately, if you don't, it also predicts 71% of those who don't gain that weight won't do well. So if you're an FBT therapist and you don't get that amount of weight gain by session 4, you should be worried because it's strongly predictive. And this has been replicated, as this slide indicates at the bottom, many times at this point across many different places and sites. This really is helpful, obviously, because you can anticipate that you might need to make some changes. Before I talk about this slide, we are doing a study right now where we have done adaptive treatments for people who did not respond early. So we developed an adaptive treatment. If you didn't gain those weights, we give you this additional aliquot of treatment. And we're comparing in a randomized trial that's actually nearing completion. We've randomized and treated all the participants who were non-responders, and we've given them 2 different alternatives. One is this augmentation therapy, and one is continuing in standard FBT, to see if this augmentation or adaptive treatment will change outcomes. We had preliminary data, of course, that it would, and that's why we're studying it at scale. One of the problems of treatment of eating disorders is being able to disseminate it and implement it across large populations of therapists and making it available and accessible. And a number of years ago now, this is not submitted, it's actually published. This was a study that we did, Alec Darcy in our group, a psychologist, did. This is a case series of 19 families. And this compared to a historical comparison, who received something we call guided self-help FBT. And this is a series of lectures that families looked at online, and the therapist met 20 minutes with them for 12 weeks to discuss what they had read. And basically, the orange ones are the guided self-help, and this is baseline, intertreatment, and follow-up. And this is weight, and this is the EDE. Again, what you see here in this really preliminary study is that they did well. They look like they did at least as well as people who were treated in our studies in terms of weight gain and changes in EDE. We did a bigger study with 40 kids this time that were randomized to FBT that was provided online. So telehealth. This was started actually before the pandemic. So we actually had been prepared to deal with the pandemic because we had been doing telehealth versions of FBT already in this study. And we compared it to guided self-help, again, provided by telehealth. And what these two slides are efficiency slides, and this is a bit of an odd concept maybe for some of you, but what we wanted to know is how efficiently the two different treatment arms, guided self-help versus standard FBT, achieved the clinical outcomes we wanted. And here we look, if you look here at this slide, so this is efficiency scores, but here's the change in the EDE for guided self-help, 1.43 improvement, 1.45 at the end of treatment for standard FBT. So no difference, right? Same here for at the end, 1.8 versus 1.22. But efficiency is the amount of therapist time that was needed to achieve that end, and highly significant differences between these two. So the end product, same, but the time, therapist time, was much less. This is for weight, again, 9.7% increase in guided self-help, 8.6 in FBT, and here this is at the end, 12 versus 10 essentially. There were no significant differences in these outcomes, clinical outcomes, but again, the efficiency, the amount of therapist time needed, was hugely different. So you can see that that's an incredibly interesting kind of study, because it indicates a couple things, that maybe because of the cost effectiveness and also ease of delivery of a guided self-help modality. And again, these were not highly selected patients. These were randomized patients showing up, in this case in Canada and in the US. This was an international study. We just didn't find outcome differences. But this is 40, so it's a small sample size. We didn't look at, we only have descriptive statistics, but the effect size differences were extremely small, except related to therapist time. Turning now to bulimia nervosa, where there's a lot less data, but these are the studies that we know about FBT and CBT. There was a case series published using FBT with 8 in 1995 out of the Mosley group. We did a case series for CBTA in 2005 with 34 subjects. Case study by Lagrange et al. With FBT for BN. We did another case series with Chapman in 2006 of 7. The two randomized clinical trials that were done prior to the one I'm going to describe was one by Ulrika Schmidt, who is a University of London psychiatrist. This is 85 people. Mean age was 17.6. And Daniel Lagrange's study, 2007 with 80. And what these found were no differences for family treatment versus CBT in Schmidt's study, and FBT was superior to supportive psychotherapy in Daniel Lagrange's study in 2007. So the answer was not clear. So this is just how these two studies looked. This was Dr. Lagrange's study. This is end of treatment. This is individual therapy, and this is family therapy. And you can see that they were statistically better. And this is percent remitted, and remitted meant in this case no binging and purging for at least on the EDE, and then for at least 30 days. And then this is a Ulrika Schmidt study. And this is interesting because this again is family therapy, not FBT exactly, but has some of the ingredients, and CBT. And there's a crossover here. They all did kind of well with remission rates 35 to 40, which is what you'd expect in CBT, but no differences in outcome. So Daniel and I did this study of 130 adolescents with BN. They were 12 to 18, and we had 18 outpatient sessions of FBT over 6 months, or same of CBT over 6 months. And what I want you to see here, the red is the FBT, and this is remission rate, and this is time. And at the end of treatment, 40% were remitted in FBT, and about 20%, 20% were remitted in CBT. At 6-month follow-up, about 30% it were remitted versus 42 or 3%. Again, statistically favoring FBT. But at the end of a year, there were no differences between these lines at 33 versus 48. The dotted lines are estimates based on, as opposed to the actual data. These are just showing you the model data versus the actual data, not much difference in those lines. So basically what this data shows is that FBT is superior at the end of treatment and at some points in follow-up, but over long-term, there's little difference. It's a little hard to interpret long-term follow-up because a lot of things happen during the long-term follow-up. But if you were choosing, I think you would want to choose FBT over CBT for adolescents with BN. And this kind of runs contrary to a lot of people's thoughts. And so it is the best and biggest study on adolescent BN out there. So I talked a little bit about guided self-help and dissemination. There have been a few studies about the impact of implementing FBT. I mentioned Westmead Children's Hospital in Australia, and when they implemented FBT in 2004, they saw a 50% decrease in readmissions over the implementation period, which was looked at over 2007. In Melbourne, Australia, again, an early adopter, they started in 2009. When they looked at their follow-up, they had a 56% decrease in admissions, 75% decrease in readmissions, and a 51% decrease in overall hospital days. So thinking about that, that's huge impacts on hospitalization and systems of care. Turning now to ARFID, there's much less data. There are no randomized clinical trials for ARFID in the literature. For outpatient care, there are some inpatient randomized protocols, but there are no outpatient ones except the one I'm going to describe to you now. We did a case series looking at FBT modified for ARFID, and we saw that the treatment was acceptable and feasible. And we did a pilot then of about, I think, 30 kids that we got treatment as usual or got FBT for ARFID. And so this is the difference. Usual care was this, and this is percent change in weight. These were all underweight kids. Usual care here and FBT ARFID here. So again, too small to do statistics on, but the effect size here was large. There's an outcome measure for ARFID symptoms, but it's called the PARTY, and this is basically no change in usual care on the PARTY scores. So these are parental reports on the children's eating preoccupations, avoidance, and so forth. And then you can see here, big change in FBT. And again, sample, the effect size was large. We looked at parental self-efficacy, which is the mechanism that has support for why FBT works. Parents go from it being perceived and felt to be ineffective themselves to changing that. And this is just an interesting, we have these data for everything, but this is the one where we did, after the end of people getting usual care, we offered them FBT. And before that, the usual care had no change in their self-efficacy scores. After they were treated, the same group was treated with FBT. Look what happened to their scores. These are what happened with the ones that, the orange ones who got FBT originally for our big change, big difference. But these caught up. And by the way, they caught up on all those measures. Their weight and their party scores all became similar to those that had originally received FBT. So it's just interesting that could happen. So with that, I think I'm at my time point, and I think now I would open myself up to questions and discussion.
I do have a question for you via a text message I got. So a question is, if say there are patients experiencing this that require medical hospitalization, and say there's hospitals that aren't able to implement this treatment, is there any way to prepare parents in advance before they step down to the outpatient treatment where they can experience FBT?
So that's a really great question in many different ways. So when we started doing FBT, you can imagine that our own treatment program, which had been highly focused around parental blame and exclusion
Right.
for many years, had to adjust. And it took a few years to change our inpatient program to being compatible with FBT, meaning we changed everything we did on the inpatient program to make it compatible with FBT. So we let parents participate in everything practically. They could stay there now. There was so much that we changed, but mostly it was attitudinal. And it took a while. People did think when I started doing this work that I'd lost my mind, and they really did. And for years, Daniel LaGrange and I were fearful that tomatoes would be thrown at us every time we talked about FBT, because there's really attitudinal bias against families. And that's really changed. It's a remarkable, huge turnaround on that. But inpatient programs still often are not designed in a way that maps easily on to outpatient FBT. There's a book Daniel and I wrote called Help Your Teenager Beat an Eating Disorder that I think would be helpful for many families to read. It's not all about FBT, but it's about all the different approaches for all the eating disorders. And FBT is one of the treatments that's described, and parents can get a sense about what it is.
Oh, that's excellent.
So that would be my recommendation.
Thank
It's
you.
published by Gilbert Press.
Gilbert Press, thank you. I'm going to make a note of that and I can share that if anyone wants to email me later. We have a chat question, which is what specific aspects of FBT have been identified as particularly useful or helpful according to the parent's point of view?
Well, that's interesting because, we have done qualitative assessments afterwards, asking both adolescents and parents about if they thought FBT was helpful and what they liked about it or didn't. And it's interesting. Most of the adolescents would say at the beginning that they hated FBT, but most adolescents with anorexia nervosa hate any treatment because they don't think they need it. And they disagree with the fundamental assumption that they need treatment. At the end, the adolescents themselves said, on the whole, I don't know how I would have gotten better if my parents hadn't helped me. And what I think that the parents reported was they felt supported by the therapist. They felt that the therapist helped them figure out the problems they were having. So separating the illness from the child and reminding the parents about that, focusing on the behaviors and getting them away from worrying about what was the cause. Those were the kinds of things parents report being helpful. During this early phases, there were a number of big changes that happened in terms of parental advocacy. There was a group called Mosley Parents that was founded that eventually morphed into a group called Feast, which these are parent advocates. And parents can now go to that website and find support for each other and information about what they've done.
Excellent. And then I have a text message. It's a more broad question, and Dr. Locke, it's what you and I were talking about when we first met up, which is if you could comment about the rise of eating disorders being seen in this pandemic.
Right. Well, couple of things. One is because of my work, I talk to a lot of people from around the world, and this is not a phenomenon unique to the United States. So the uptick in referrals for eating disorders generally, and particularly for anorexia nervosa, hospitalizations rates and referrals are extremely high. And we had it here at our center as well, so it's everywhere. I don't know exactly why, of course, but I have some ideas. One is that during the early parts of the pandemic, parents and families in general avoided medical care. They didn't go to the doctors. So there was a long period of time where basically symptoms and behaviors went unchecked because of anxiety about going to a doctor's appointment to have it evaluated and checked. So kids had a longer period of time in which these behaviors and cognitions kind of festered, and they lost more weight. So it's not in our center, and I think most places, not just that there are more of them, they're actually lower in weight and medically sicker than they were before, when we would get them in sooner. So that delay has a long-term impact in terms of, both the response probably to treatment and the severity of the medical compromise that you're seeing. And so stays are longer, which makes everything else backed up more and so forth. Now, why might there be an uptick in general? Well, I think the general information that we have out there is that people with very less, with all the social deprivation, focused on things like eating, and they drank more, they ate less, they exercised more. So people who are prone to use those things unproductively were essentially put in a milieu of isolation that really allowed the behaviors to get stronger and stronger, and in vulnerable individuals increase the manifestation of the illness. This is what I think happened. And a lot of it has to do with my view about why some people are resilient to AN and some people are not. And most people can't happily, most people cannot develop anorexia, so we're just not capable. We aren't able to deny reality so much that we will run when we're starved, and we'll see ourselves as overweight when we're not, and be able to eat so little despite the fact that our body's craving food. Most people cannot do that. But there are people who could do it, who don't ever get caught in it. But this situation of isolation and preoccupation and no other things to do but sit on Zoom or whatever, these kids, more of them are vulnerable to expression.
Mm-hmm. We have another question in the chat box. Any evidence to suggest that compliance of care was improved with FBT compared without parental involvement? And were there specific indicators that might make FBT not indicated?
Two very different questions. So compliance is an interesting question. What I can say is that people in our studies were required to have ongoing medical evaluation to make sure they were safe for outpatient care. Dropout, as I mentioned, was really low. But that was true for AFT. It was also true for systemic family therapy. There were really no differences. So I wouldn't say that FBT led to, quote, greater compliance. Maybe being in a study does. Just anecdotally, and from a clinical point of view, we have seen in FBT generally, because parents are in charge of things, whether it's in BN or AN or ARFID, that there is the attention being paid to helping them be responsible does lead to greater adherence to general protocols. The other question was, what was it? There was two. The end of that was another one.
Oh, yes. Any contraindications for FBT?
Yeah, so that's a great question, and one which I wish I had a better answer to. But one thing I will tell you is over many years, the clinicians in our studies would try and guess, oh, this family will not do well, or this one will do well, and we're terrible at it. So the first thing I would tell you is don't think as a clinician that you're going to know,
Okay.
because you're not, unless you're so much better than our clinicians, which is possible, but we have pretty good psychologists here. So, and psychiatrists who are doing these treatments. We gave up in the end. We said, we're just not good at that. Really a reminder to be a little bit humble about what we think. What we have not found are any baseline predictors of non-response. So we looked, but the non-response rates are low. Remember, there's only a small percent. What I will tell you is this: there are some things that one is, if families say, I don't want to do this, I'm not going to do this, don't try and make them do it. That's just a recipe for not a good outcome. If they're open to trying it and ambivalent, yes. If a parent obviously has a mental health or physical health disability that so limits their ability to care for themselves, let alone their child, they're not good candidates. So if you have a psychotic parent, but what I will caution on this, having a history of eating disorders in the parent is not something you should immediately say they're not good candidates for this treatment. What I've seen in families is sometimes those parents are excellent because they understand the dilemmas. If they have themselves recovered from an eating disorder, they often can be really helpful. If they're in the throes of anorexia and nervosa themselves, they are less likely to be helpful. But we have not had predictions that eating disorder diagnoses in parents have any validity. The other thing is if parents are actively divorcing, like right now they're in the battle of divorcing, not if they've been divorced, but if they've been if they're in the fight, it's very difficult for them to work together. And you do need parents to work together. By the way, single parents do well in FBT. It takes them a little longer, but they do well.
Thank you. I have time for just one last question, which is in 1997, Peggy Claude Pierre wrote about the secret language of eating disorders. It was controversial then. Just curious if there's been any further development of our theory that some ED is secondary.
Yeah, that book, which I remember reading a long, long time ago now, was controversial, still is, and I don't think so. I don't think there's been any additional. One of the things that is extremely disappointing is that the amount of funding and focus on anorexia, bulimia, and children's eating disorders generally from a national health perspective is so small. I mean, the number of researchers in the field is extremely small. And that's because the resources to conduct research are not there. So therefore, it doesn't draw researchers to the field. So until we get a more robust commitment to changing our attitude towards the seriousness, which is so obvious, highest cost illness from a medical point of view, aside from schizophrenia, and it rivals it. And second, huge morbidity and mortality rates in very young people. Until we actually really own that and say this is a really big problem and put money behind it, it's going to be hard to make progress on any theories.
Absolutely. Well, that is all the time we have left for today, but I just want to thank you again, sincerely. We really appreciate you taking your time out of your day today to talk about this very important topic.
My pleasure, and thanks so much for having me.
Bye, everybody.